as Miriam said, I'm a health economist and I work with various disease models and thinking about how disease models fit into health system models and how health system models fit into societies. And so I thought in this short presentation, what I'll show you is I'll help you to start thinking about some of the mechanisms through which political and social features impact the health system and impact the actual epidemiology of COVID-19. And so let's start from something very basic and think about the biology and the epidemiology, move on to the health system, and then think about the model which the health system sits within. So that's the plan. And this is our exam question, really. Why have different countries experienced different levels of mortality from COVID-19? So that's kind of the question we want to answer or predict. And we want to think about these whys, these reasons, the causes to be fundamentally social and political characteristics of the different countries that determine these differences. And so, as I said, we'll start by talking about the epidemiology, then we'll say something about the health system, and then we'll bring in the social and political factors. So this is a basic kind of epidemiological workhorse model that's used to look at diseases like COVID-19, and it's called the SIR model. And so in this model, we have people in states, and they're healthy or susceptible, they don't have any immunity, and they can be infected with the virus. And so those people, they start off as susceptible, they can become infected, and after being infected, they can recover. Right. And so the first step is you catch COVID from somebody who's infected. The second step is you recover. And actually, we very quickly realized with COVID that actually you can catch it again. So after some time, your immunity wanes and you become susceptible again. And now the first thing you'll notice from looking at this model is, well, it doesn't talk about our exam question about people dying. Where do people die in this model? And so we can add on an additional bit to the standard SIR model to say actually a proportion of people who get infected will die of COVID. And the main kind of feature of this model, or the main kind of modifiable aspect of this model is the blue arrow, the rate that people are catching COVID, the rate that they're getting infected. And so we can start by thinking about what impacts that rate or what determines that rate. And these arrows you can think of as differential equations linking the states together, right? And so your chances of catching COVID, that's determined as a function of how many people are already infected, how many people are susceptible, how infectious the disease is, so some kind of a description of the biology of this bug, and the behavior of the infected and susceptible people. And those last two things, the infectiousness of the disease and the behavior of the people, combine together to give us what many of you will have heard of as the R number, or the reproductive number of the disease. So what is this R number? So the R number basically says if one person is infected, on average, how many other people will that infected person pass the disease onto? So I've drawn up a little example with comparing an R number of 2 and an R number of 3. And these kind of sad faces are sick people. So at time 0, there's one sick person in each of these kind of 2 parallel worlds. And at time 1, you can see where R equals 2, the sick person infects 2 more people, whereas at R equals 3, they infect 3 more people. And so this kind of seems fairly similar at time 1. Then we get to time 2, and we can suddenly see, oh, wow, where R equals 2, we've only got 4 more people infected, whereas when R equals 3, we've got something more like 9 more people infected, right? And then we go one more step, and we can see that there's this exponential difference. So this kind of linear difference in the R number, fairly modest difference in the R number can have massive differences in the numbers of people getting sick with COVID. And I mean, to put this in the current context, thinking about the latest variant, and for those of you who are in London, you kind of seen this anecdotally, that where everybody seems to have it. And from what I've heard, there's this kind of health systems people are using a working assumption of the R number being closer to 10 or 15 than 2 or 3, as they were thinking about the initial variant. So this R number is a fundamental epidemiological factor, right? And what determines the R number, as we said already, it's the infectiousness of the disease. So this is kind of something biological, and it's not something we can really modify. Plus, it's the behavior of the susceptible and infected people, and that is modifiable. And we've seen various measures to try and modify this, like lockdowns, social distancing, wearing of masks, testing, tracing, isolating, quarantining. So all of these kind of non-pharmaceutical measures to try and control the virus by changing our behaviors can change the R number, right? And so as soon as you understand that, you can intuitively grasp that the R number is unlikely to be the same in all places. You can imagine that in the UK, the R number is probably very high in London as compared to a small village in the countryside. And you can imagine how that difference in behavior might translate across countries. And we'll talk a little bit more about that as we progress through this presentation. And as I said already, small changes to the R number can have very large changes on numbers of people having COVID and mortality. So there's this kind of epidemiological model is fundamentally nonlinear, and it's actually exponential. Right. So we've talked about this in a very kind of epi sense. But what about if we bring in the health system? And the first thing we can do is we can bring in hospitals, right? And so we can say that there's two. Now, when people get infected, they either have mild COVID and they'll just recover and it's fine, or they get severe COVID and they go to hospital. And they'll need some treatment. That might be oxygen, that might be ventilators, that might be some kind of treatment or the other. And so those severe cases, they'll either be treated successfully and recover, or they'll be treated unsuccessfully and they'll die of COVID. And again, that comes back to our exam question of people dying of COVID and what happens and how do we impact that, right? And again, there's kind of modifiable and non-modifiable factors here, right? And so one of the things that impacts your likelihood of getting severe COVID is the age structure of the population. So older people are much more vulnerable and likely to get more severe COVID, right? So that's one of the things that we discovered very early on in the epidemic, right? Other factors, however, may be modifiable by things like good public health and primary care. So some of the things that also make it more likely for you to get bad COVID are things like comorbidities. So if you have some other diseases such as diabetes, hypertension, or if you have some risk factors as things like obesity, then you're more likely to get severe COVID, right? And so some of the things that the health system can do, particularly in providing good primary care, preventative care, can help reduce those comorbidities in the population and reduce the likelihood of people getting severe COVID, right? The next thing that we can think about when we bring the health system in is the health system capacity. And so when people get severe COVID, they go to hospital. Now, when there's hospital capacity, that's fine. But at some point, so many people are going into hospital that the hospitals can't cope anymore. The hospitals get overwhelmed. And so in many countries, there was talk of what they called flattening the curve, saying that we need to reduce the number of infections at any one time so that the hospitals or the health system can cope, right? Because there's only so many healthcare professionals, there's only so many hospital beds, there's only so much oxygen, ventilators, etc. And so when you overwhelm the health system, your likelihood of being unsuccessfully treating patients increases and more people die versus the people that you're treating successfully, right? And so your health system capacity is one of the key factors. And thinking about what you've already done, how much you've invested in your hospitals, how many free beds you have, how much capacity you have, may tell you something about your likely mortality rates from a disease like COVID, right? The other big thing, of course, is vaccines and more recently, maybe treatments as well, right? And so vaccines work in lots of different interesting ways. So we can see here, right on the left-hand side, vaccines can take people from being susceptible to immune without having to go through infection. So you can immediately give people some immunity. The other thing we've noticed much more with the COVID vaccines is that even if you do get infected, they can make it much less likely that you get severe COVID. And even if you get severe COVID, it's much less likely that you die from COVID. And so they reduce the severity and they increase the likelihood of successful treatment, even if you do need treatment. And so there's lots of ways that vaccines can help. And so this is kind of where the pharmaceutical, so we talked about non-pharmaceutical interventions. These are the kind of pharmaceutical interventions like vaccines, and increasingly we'll see treatments where you go into hospital and they've got various medication that they can use to help you get through COVID, as well as just understanding disease better and understanding how to manage patients through it. The other thing to think about is, and I mentioned this a little bit, is flattening the curve, how many simultaneous infections you have versus how you can spread those out. So it's not just the cumulative number of infections over time that's important, but it's when they occur. And if they all occur at the same time, that's where the health system gets overwhelmed, and that's where your death rate really spikes, right? The other thing that we can think about is the value of delaying cases. You know, you may think that eventually everybody gets infected anyway. What's the point of changing the timing? So one thing is about health systems getting overwhelmed. The other is that things are being, new technologies are being invented all the time, right? So people have made vaccines. So if you managed to avoid getting COVID until the vaccines came out, you had a chance of being vaccinated, which reduces your chance of getting severe COVID. And treatments are coming out. And so delaying infections has various advantages that can reduce mortality, right? So now let's move from the health system to social and political factors and think about how those may have influenced the model parameters that we've talked about already, right? So the first thing that we're going to do is actually, I've been telling you our exam question is about how many people died of COVID, but actually our exam question is about how many people were reported dead with COVID, right? It's not quite the same thing. And so when we start talking about social and political factors, that difference might become important, but we'll come back to that. So the first step, let's go back to this idea of what causes you to catch COVID, right? What causes susceptible people to get infected? And there's a bunch of stuff, and one of the important things is the living and working conditions that you endure, right? And particularly in cases where these are very unequal, these social determinants of health, as we call them, are unequal. It's increasingly likely that people living in poor areas, working in riskier jobs, living in more densely crowded environments are more likely to catch infectious diseases, right? Then there's this idea of, so we talked about the non-pharmaceutical interventions, things like mask wearing, things like staying at home, lockdowns, all of these other things. And a lot of them rely on some kind of level of trust in government. The government tells you to do something, and do you follow that? Do you believe the government's talking in your best interest, and do you actually adhere to those measures, right? And in some countries, they may be able to enforce those things more successfully than in other countries. In other countries, they may have to rely on trust. There was talk in the beginning of the pandemic how more autocratic governments may be able to implement these measures more swiftly and more effectively. And so there may be something about that. But on the flip side, the trust in those governments may differ as compared to democratic governments. And then there's also this idea in trust in each other. And, if you believe that nobody else is wearing a mask, what's the likelihood of you wearing a mask, and vice versa, things like that. Thinking about altruistic behavior, are you willing to inconvenience yourself for the benefit of others? And what creates those altruistic behaviors or trust in societies? Is there something about the economic or political system that we can measure that would be a good proxy for these ideas of trust in government, trust in each other, altruism? Inequalities, of course, is one of the other key factors there, right? So that was the first idea of the infectiousness. And then we talked already a little bit about the severity. What makes it more likely for you to have, or more or less likely for you to get severe COVID? And, and we said already, some of these factors are really not very modifiable, like the age structure of the population, right? But other factors like comorbidity profiles can be influenced by public health and primary care investment. So you could think about things like the proportion of your government spending that's gone into public health and primary care, or into other basic social determinants of health like housing and employment and education and various other key determinants. And many of these comorbidities can be seen as symptoms of inequality. And so in more unequal societies, you may find that actually you have more of these comorbidities, or these comorbidities are particularly concentrated in certain parts of the population, right? Next, we look at health system capacity and what kind of social and political factors might influence health system capacity. And so here, really, we're talking about the amount invested in the health system. That will tell you how many hospital beds you're likely to have, how much, what kind of healthcare workforce you have, do you have oxygen, do you have ventilators? And this will be determined partly by your overall GDP, and partly by your political priorities as to what you do with that GDP. How much do you care about healthcare versus other things? And then the other key factor that comes in here is the willingness or ability of the government to impose COVID suppression strategies, right? So things like lockdowns, and again, it comes down to political priorities. Are governments more worried about what businesses say, so there's various competing priorities, and different governments may see those differently, right? So are there indicators that we can use to start thinking about where we think a government might go? And for all of these factors, you can see very clearly where if governments were more willing to suppress infections, or if they invested more in the health system, that would clearly be correlated with lower levels of death, right? Like according to the mechanism that we've been talking about. And finally, we can talk about vaccination. And so as we said already, there's this kind of ability to keep infections rate down until vaccines become available. So how good were countries, or how able were countries to keep their infection rates low enough until vaccines became available for the vaccines to take over part of that burden? And then there's this kind of simple constraint of being able to purchase vaccines. So there isn't enough vaccines for everybody in the world. We've seen that. Vaccines have been concentrated in richer countries, and the vaccines have been designed in such a way, or developed in such a way, that actually it's not that easy or cheap to deliver them. You need quite complex and expensive infrastructure to be able to store some of these vaccines at very, very cold temperatures, and to have those kind of cold chains and supply chains in place is expensive. And of course, you need the workforce to be able to deliver those vaccines. The next thing you need to do, even if you have the vaccines, is you need to convince people to take them. And again, this is something that really depends on trusting the government, trusting the healthcare system, trusting the pharmaceutical industry to some extent. And so thinking about what it is that builds that trust. And one of the key things that has been observed in many countries is that inequalities, and particularly racial inequalities, have been very crucial in vaccine hesitancy and eroding that trust. And the other thing that, of course, is very relevant here is kind of the misinformation, fake news, and conspiracy theories that go around. And those, of course, gain traction where trust is low, and that fuels vaccine hesitancy and also non-compliance with other kind of COVID suppression measures. And finally, we have this idea of the kind of potential disconnect between the number of people who die of COVID and the number of people who've been reported to have died of COVID. And partly that's to do with, do you have good health systems and national statistics infrastructure? So do you have a good way of collecting mortality data, attributing it to the right causes? And that's going to be influenced by the amount you spend on various health information management systems and other things, right? And then you may also find in some places the political leaders are able to hide the numbers of COVID deaths and incorrectly report them because it's in their interest to do so. And so you might find in places where there isn't a thriving independent media, that's much more difficult, where there's more accountability and transparency, that's much more difficult, whereas where there's a lot more political corruption, that might be easier, right? So just to finish off, in summary, some key messages. The epidemiological and health systems models, they give us a useful starting point to think about how COVID deaths occur. What's the mechanism going on? And we saw that many of the parameters in these models are modifiable and they're shaped in social and political context. So that gives us the mechanism to think about why should some difference in social or political context change COVID deaths, because it impacts certain things in the health system, or it impacts certain things in the epidemiology, or both. And those things feed through, as we've seen from our model, into COVID deaths, right? And the other thing to keep in mind is that the models that we're talking about are complex and non-linear. Okay, they look quite simple with a few boxes and lines, but actually small changes in some of these parameters that go into these models lead to huge changes in the number of reported COVID deaths.